All right? Okay. Okay. So I will present a few, three short cases that I think that are very unique or not that usual. So this one is a 52 years old female, has previous history of smoker, no significant risk factors, prior fem bypass, and prior right iliac stent. Severe claudication pain included rest pain in both legs, increasing in the last 4 weeks. So it's a patient with prior bypass that it has rest that has pain in both lower extremity and previous fem bypass. So I brought the patient, and this patient had a complete occluded distal aorta. So if you see here, you see the distal aorta, and you see there is reconstitution of the vessels below here. So I know that she had a fem bypass, and I know that she has a right iliac stent. So because of that, the problem has to be in the stent that is on the right side, because the left side has to be occluded from before, otherwise the patient would not have a fem bypass. So if this was an acute event because it started suddenly 4 weeks ago. So what I did is I went forward and went through the iliac stent, and it got into the bypass. And then I put an infusion catheter in there and infused thrombolytics for 18 hours at a rate of 1 milligram of TPA an hour. In order to do that, you got to do also heparin, because the patient will start to release thrombin, and there are complications related with bleeding that you have to control. Sometimes you got to decrease the doses of thrombolytics, and in order to prevent bleeding complications, it's better the heparin to put it through the sheath. So what I do is I have the catheter and I have the sheath, and I put the heparin through the sheath. So I bring the patient back the following day, and you see now that we see the bypass that is open and is filling through the bypass. And if you notice up here, this is the stent that probably what the patient has an acute occlusion of the stent, and we have some residual disease in here that I treated with the balloon and another stent. And you see here now we have a wide open right iliac that it goes down to the same leg, and then through the bypass goes to the other leg, and we have the distal flow, SFA popliteal, and three vessel runoff. So this is a very interesting case in the sense that it was an acute occlusion of the stent that produced complete occlusion of both legs at the same time. And if you recognize that, the treatment was the one that I showed you. Redo surgery would be a real challenging case. Another case is an intervention in infrapopliteal disease, 72 years old female, diabetic, hypertension, history of coronary artery disease, chronic kidney disease, stage 3, typical patient, and started with a small sore in the right foot, progressed to a small ulcer that is not healing, no digital pulses. I didn't feel pulses, but interesting, the patient ABIs was 0.9. And this is an important issue because in diabetic patients, ABI might not be as realistic of the degree of ischemia. So because there was no healing ulcer, I took the patient directly to the CAT to do an angiographic study. And if you see, there is no disease in the iliac and SFA system, but there is a major disease in the below the knee. There is almost no vessels that communicate, but if you keep following down, you do see a vessel that reconstitutes here, and it goes to the foot. So I tried to go antegrade, and I couldn't, so I went retrograde, and retrograde, I was able to open the retrograde limb, and then I get the wire into the SFA, I capture the wire, and we get the wire. That is kind of weird. I don't see here. I don't see here in the normal way. Is somebody? Do you? Yeah, I don't see. I don't see the slides in here. Yeah, you see it there, but I don't see here to be able to click. So why it is like this? All right. Apologize. So we see that we capture the wire and we remove the wire backward. And then we sterilize the wire. And after that, we reverse the procedure. We do balloon and we reestablish flow all the way to the food. So we reestablish flow all the way to the food, and then we have a straight line to the appropriate place. I wanted you to mention that it is important to have a knowledge of what is called angiosome. So if you have a lesion in the big toe or on the second toe, you need to get circulation to the anterior tibial artery, whereas you have problems in the fourth, fifth toe, or more on the ankle area, you need to get flow into the posterior tibial area. So 78 years old male, history of smoker, no other significant risk factor, no prior claudication symptoms, had a sore in the right foot and the right big toe after accidental drop of a can of Coke, and after that he went to a small ulcer, painful, no improvement after 3 months of local treatment. And this one, you see again, normal arteries, SFA, popliteal, and everything is okay. And then when we go below the knee, we have a good vessel here in the middle, but we know that this artery does not go to the foot. And if you see here, the one that goes to the foot is this artery that is 100% occluded here. Okay, so this artery that is filling via collaterals is the one that actually goes to the foot. The other arteries do not reach the foot. So you do think that you have an artery that goes, but it doesn't. So I tried to do an opening of that artery antegrade, and you see my macrocatheter is here, and if you see the artery, I am completely out. So I tried to re-enter, and I couldn't re-enter. So if I look at the angiography, I notice that the collateral is coming through the other artery, and what I did is I went through that collateral, so I went through the other artery and backwards through the collateral, and then going backward to the collateral, I was able to get the wire up into the, you see the wire going down and up, and then keep going up, and comes up into the true lumen. And then we reverse, as I reversed it before, we balloon, and this is the final picture that will reestablish flow through the appropriate vessel that goes to this place. So, very important to understand the anatomy. The last case is 81 years old female, history of prior smoker and coronary artery disease, status post-PCI, non-diabetic, back problems for years, status post-back surgery. Patient continue having pain in the right hip area related to walking. No pain in the left leg. Distal pulses in the right leg were diminished. Left leg pulses were normal. ABR in the right leg was 0.6, in the left leg was 1.02. I did a CTA in this patient, which shows an occluded right iliac artery and no other obstructive disease. So the patient actually said that even with the back surgery, she never improved. So unfortunately, I couldn't get the subtracted images, so they are not as good quality, but you will be able to see. This is the access in the right leg, in the left leg, because I'm going to fix the right one. So I went from the opposite one, and you will see now a picture that it shows that there is an occlusion right at the level of the takeoff of the internal iliac artery. So So I tried to do an intervention. This is the pictures, and because of the CTA, I didn't do farther down because I knew that they were normal. So I tried to do an intervention retrograde, but my wire was going subintimal into the aorta, so I was not able to get the wire retrograde in the right place. So I switched the intervention to do an intervention going from the opposite side, and I did a reverse card, and you see here the balloon inflated, and then after I inflate the balloon, I go with my wire retrograde into the lumen, and it will go up into the aorta. So now I'm on the true lumen. So after that, I balloon antegrade and continue and doing the whole segment balloon, and then I put a stent. And when I release the balloon from the stent, all of a sudden the patient became a kind of restless, and we didn't know what was going on. It looked like to me to put the stent and I was going home. And we look at the blood pressure, and all of a sudden it start to drop the blood pressure. And if you see, we have a complete massive perforation of the iliac artery. So this is a very risky perforation. It's not like in the heart that will drop a little bit. This will drop a liter of blood in less than a minute. So because it's a very sizable perforation. So unfortunately, I didn't have the balloon in the patient because I didn't expect that this perforation would happen. If I would have paid attention to the calcification, it was very calcified, and I did a reverse card. Probably this is what is produced. The hole when I put the stent is one did happen. With the balloon, nothing happened. So because of that, I got a triple access. So I went into the iliac because if you deflate the balloon to put a covered stent, it will have a massive bleeding. So I did a triple access. I went into the radial artery. From the radial artery, I put a wire in here. I put a balloon in here, and then I deliver a covered stent from below and removing the balloon from above. So deflate and inflate rather quickly. All right. So after that, the hematoma, the perforation completely resolved. You have to have the ability to do this. Otherwise, I will not do iliac intervention. It's much more common in the external iliac than in the common iliac. This is something that you will not see that often, but it's very interesting. This is the bladder sign. You see, this was when I was doing the procedure, and this is the bladder after the patient started to bleed, how the amount of blood that is in the retroperitoneal compressed the bladder to the other direction. So I think that's the last case. Thank you for your attention. I hope that were interesting.